The behavioral effects of THC are quite numerous, and so at low to moderate doses or for acute ingestion, you can see disinhibition, relaxation. The patient's alertness tends to be reduced, and patients will experience drowsiness. There's an overall feeling of euphoria. Some patients do report exhilaration. There are sensory and perceptual changes, and even short-term memory impairment. Balance and stability is impaired, and there's also a reduction in muscle strength, and in some patients, a small tremor. More complex motor tasks, such as driving, are typically done with poor performance. At high doses, or in acute overdoses, you can see pseudo-hallucinations. There's dramatic impaired judgment with reaction time, especially with driving. There's pronounced motor impairment. There's increased disorganized thoughts, confusion. Some patients become paranoid and highly agitated. And then in young patients, we can also see the altered brain development. The physiologic effects come from the fact that there is some anticholinergic activity associated with these drugs. So you can see dry mouth. Chronic bronchitis is really seen in patients that are smoking marijuana. The THC itself is not going to exacerbate or make asthma worse. Actually, in fact, THC is a known bronchodilator. However, the smoke associated with the joint is actually a bronchoirritant. There is going to be dramatic changes in both blood pressure and heart rate. You can see increases between 20 to 50 beats per minute in some patients. There's going to be dramatic suppression of neurons in the information processing components of the brain. And there's going to be some tolerance and mild physical dependence with frequent use. And so we talked about earlier in the previous video that THC and associated congeners do affect the dopamine/reward pathway. But in spite of all this, THC has some therapeutic uses. Cannabis and cannabinoid type agents are widely used to alleviate symptoms to treat lots of diseases. Their efficacy and their specific indications, however, are not well established. For chronic pain, the analgesic effects remains unclear. We talked about the association of cannabinoid receptors with mu-opioid receptors, both physically and spatially in the brain. There is the best known use of cannabis, probably in the therapeutic setting, is an analgesic in the management of cancer patients' pain, as well as post-operative and phantom limb pain. Cannabinoids have also been used in the prevention of nausea and vomiting caused by some of the chemotherapeutic drugs, and to stimulate appetite in patients that are receiving palliative care for anorexia caused by opioids, anorexia caused by a very intense eating disorder, antiviral drugs, wasting syndromes associated with AIDS or related illnesses, and terminal cancer. The effect on bronchodilation was just talked about. THC itself is a bronchodilator, yet the smoke associated with marijuana joints is a bronchoirritant or slight bronchoconstrictor. It is paradoxical that cannabinoids have been reported to be of therapeutic value in neurological disorders associated with spasticity, ataxia, and muscle weakness, because similar symptoms can be associated with acute use of cannabis in and of itself. Another compound that we should discuss is cannabidiol, or cannabidiol, also known as CBD. It makes up about 40% of a typical cannabis extract. This particular compound is important because there are no psychologic or psychoactive properties. So it does have a potential therapeutic for at least the cannabinoid receptors, or for the endogenous receptors that are not cannabinoid, CB1 or CB2. So these would be like ion channels, enzymes, other receptors, and so forth. And so we would classify this as like off-target binding. So CBD would be binding to other receptors than CB1 or CB2. There has been some reports that this might even be an antioxidant or oxidative property. arguing for its use as an anti-cancer agent for adjuvant therapy. THC has also been shown to have antioxidative properties as well. For CBD, the kinetics, also this drug is highly lipophilic, It's also metabolized by the CYP-P450 enzyme system, specifically CYP3A4. There would be potential drug-drug interactions. It is not a substrate for P-glycoprotein, but from another cytochrome P450 enzyme that is clinically relevant would be CYP2D6, and this extract, or this isolated compound, I should say, has been known to inhibit CYP2D6, and it's clinically relevant. CBD effects include, based on human studies, of course, the physiologic, minimal physiologic effects. There's really no changes in respiration or cardiovascular complications. The neurologic effects, there can be an acute anxiolytic effect, some antipsychotic effect, as well as affecting fatigue. There is an anti-inflammatory and a GI effect, but minimal adverse effects overall. If we were to co-administer this drug with opioids to reduce the opioid dose that has been suggested, early studies have demonstrated that co-administration of this drug with opioids was safe and well tolerated, which is kind of paving the way for the use of CBD as a potential adjuvant therapy for opioid patients that are maybe on escalation doses and you're worried about addiction manifesting itself. You can also see CBD done in combination with THC, which would allow a lowering of the THC dose, which is interesting. There's been a very limited number of human studies on the effects of CBD, particularly chronic studies or long-term studies that examine this role. So this is the main two topics in terms of marijuana, both THC and CBD. I expect we'll have more knowledge and more information to share with you in the upcoming years as these drugs become basically more and more mainstream and less regulated. So this will be an interesting discussion to have 3 years from now. Thank you. If there's any questions, please email.